Okay, so miigwech, for those of you who came at the end of the day, I really, really appreciate the fact that you've done that, and really, really look forward to having an hour to spend a little bit of time with you. So Lori and I are each going to introduce ourselves. I'm going to give you a short presentation of some of the work that we've done. And then I'm really looking for, having a real knowledge exchange and knowledge sharing. What I loved about the idea of coming to this event was it was a knowledge sharing event. And I think we're all on this journey together trying to find the best way to provide end-of-life care to people in many, many different settings of care. So I'll introduce myself first. My name is Mary Lou Kelly. Personally, I'm really pleased to be here, like I said, on the Treaty 7 territory, and really to value the opportunity to be at a knowledge exchange like this. I now live in Ottawa, which is the unceded territory of the Anishinaabe Algonquin, but I really spent most of my life, my spiritual home is in Thunder Bay, Ontario, the shore of beautiful Lake Superior in the traditional territory of Fort William First Nation. And over my career and my life, I've had the privilege to learn from lots of Indigenous people, students, colleagues, staff, and I've always tried to be an ally and feel like I'm a better person for having known all the Indigenous people that are in my life. So professionally, I'm a social worker. I worked for 10 years in the healthcare system and then moved over to Lakehead University, where I spent 35 years teaching and doing community-based research. I founded that center, which is now known as SARA, and worked with Holly Prince and Lori on the End of Life Care and First Nations project from 2010 to 2016. And then I retired in 2015. How's that going? But I got invited back in 2020 by Dr. Sharon Castleinen from McMaster, and we had the opportunity to get some funding from Health Canada to share some of the resources that we've been developing for infusing the palliative approach in long-term care. And I really wanted to do what I could, particularly in the context of reaching out and extending some of the work to support Indigenous communities, which was something that they hadn't done up until this time. So I'll turn it over to my wonderful colleague, Lori.
So Mary Lou invited me last minute, so I said yeah. So I want to say Sego Gwego. Greetings to everyone. Lori Youngits is my name, and I'm Mohawk Gayank Gahaga. So and my clan is Wolf, so that explains a lot. Yeah, I've been working in home and community care now for 24 years, and I met Mary Lou in 2010 when we started the research project. Her and Holly came out to Six Nations in Ontario, and that was the beginning of where we are now. So, and the journey continues. So I know
here we are.
Yeah. So I'll let you go and do
Sure. So I'll just start by sharing with you a little bit about this SPA long-term care. SPA sounds like we might be getting a massage or a manicure. Sadly, no. It means strengthening the palliative approach in long-term care. And the SPA project has been going for about 20 years. It is not a new project, and Dr. Sharon Castleinen from McMaster has been the lead. I worked with Sharon in the early years with the long-term care project, and then went on to work with Lori and her team, and Sharon carried on. Much of the original work was research and knowledge creation, but the Health Canada grant is not research. We are not here about research. We're here about sharing what we've learned so far and seeing how any of that could help support or inform the work that is going on here at this knowledge exchange. So, see if I'm hitting the right button here. Nope. Which button do I?
It takes a minute.
Oh. Is this forward? All right. Does somebody want to move my slide forward?
There it is.
Great. So this is just an acknowledgement of our funding from Health Canada. We're very, very grateful for that. And an indication of some of the partnerships we've formed. SPA is a national alliance, and we highly value the collaboration of groups like the Canadian Virtual Hospice that you would have seen out in the lobby, Canadian Hospice Palliative Care, who help us with a collaborative community of practice. SE Health First Nations, Inuit and Métis program are our major collaborator in this Indigenous component of the work we want to do, and the BC Centre for Palliative Care. And you would have seen also some of the excellent resources that they have out here. So the next slide, if you don't mind. So this is a graphic of the result of 20 years of work. It's funny how you can just put it on a little picture there. It's what we've learned so far. And I say the whole circle would represent either a long-term care home or the place in which the person receives long-term care. And I would acknowledge that in many Indigenous communities, having a freestanding long-term care home is not the reality. And for many communities, it would not even be what they would choose to do as a model for long-term care. But it is part of the continuum of care. And my understanding is that there are probably around 40 long-term care homes already in Canada. So just imagine that this is the place where someone depicts long-term care. And this is what we believe is required to do the palliative approach. So that yellow circle really depicts the major, I'm going to pick this up because it's so small now, depicts the things that we think are really important in the palliative approach, the white circle. And that is making sure that there's really good pain and symptom management for the individual, making sure that they, their family, and the community is well prepared as far as what to expect. The relationship between the long-term care home providers and the individual and the staff is critical, and quality of life is, of course, the goal. So those are the main components. So in the inner circle, the green and pink and blue are the various components of the program. So there are palliative care conferences and tools and resources to help support that, because we found that is a very effective way to communicate with the family and have everybody understand. It supports preparedness. Bereavement care. The palliative care champion team, which is the healthcare providers that are doing the work, coming together and supporting each other, is very, very important. They're local within the home. The comfort care rounds, and they've been effective with expert palliative care providers who can come into the home and do chart reviews with the staff and really help support them and guide them in the care they're doing. Staff education about the palliative approach, it's a major part of what we've done. And information about illness trajectories, again, supporting being prepared and very important information for families. And then the outer circle is really how we've done our work, the quality improvement approach, where there's a champion team within the long-term care home or organization. They do a self-assessment looking at where their strengths are and how they might want to learn some new skills, get education and coaching opportunities, supporting the team, and optimizing the use of external consultants where they exist. So that's kind of the holistic approach that we in SPA have developed and evaluated and tested in many long-term care homes. So I'll just ask you for the next slide. So these are just a little, I've got on each of your tables samples of the various resources we have, and they're all out in the lobby. But what we're hoping to do is, with some Indigenous partners that would be interested in working with us, to co-design and share some tools to support frontline staff to manage difficult situations. As has come up, conversation is often the hardest part. How do you start those conversations? A lot of the pamphlets and resources are excellent tools to get that conversation going. There's a sheet there where families can be prompted to ask questions at care conferences, get the information that they need, resources about bereavement support, various ways that other residents, families, and staff can be supported, and all kinds of educational resources about the palliative approach. So maybe the next slide, please. We have resources designed for residents and families. The trajectory brochures have been extremely popular. We have them on the 5 sort of most predominant health conditions that residents have in long-term care, and things like frailty and dementia, lung disease, heart disease, etc. And it really helps the family understand the typical progression of the illness and what kind of questions they might be asking the staff. So often the staff are reluctant to start the conversation, but it often can be the family coming to them and saying, like, I see things are changing with my loved one. Can you help me understand what's happening? Next slide, please. So we're really here to invite those who are interested to join us in a virtual community of practice where we can continue this conversation that started in the last couple of days. And there is a QR code on the table where you can fill in an indication of interest. I've got some hard copies, and there's also an email address if you want to let me know of your interest, and I'll get back to you. Next slide, please. So we have a social media presence, and you can follow us on any of those social media sites. New information about resources that we're posting to the website. Next slide, please. So we have a YouTube channel. It's got all kinds of informational videos by healthcare providers from different disciplines, nurses, physicians, social workers. No, I didn't do a video, I did a podcast, but lots of things there. Oh, I think I went ahead, sorry. This is the e-learning modules, and these have been extremely popular because staff can do them at their own pace, at their own time and convenience. They're very, very short, and yet they cover all of the key components of the palliative approach for care. They're on our website. Everything is free, and people can use all these resources for staff education and training. Okay, next slide. Okay, there's our YouTube channel. I don't know how many videos there are, but there's lots. Next slide, please. Podcasts. So again, I don't know, it's probably a generational thing, but all my children listen to podcasts. They don't seem to read anything. So we thought podcasts, again, different learning opportunities, different ways. So we have all these podcasts I talked about, including we would love more Indigenous voices on our podcasts. Some of you who have presented at the conference, I will be calling you, asking if you would consider doing a podcast. We have two excellent ones from one from Elder Geraldine Smith, who I understood wanted to be here with us. I worked with her closely at Peguis, and but she's having a few health challenges, so she couldn't make it at the moment. And Holly Prince, well, nobody knows Holly, so why would you listen to that podcast? No, just kidding. But Holly did one about a lot of the resources that she's worked with the Canadian Virtual Hospice. Next slide. This is just more examples of our resources, and based on reading the pamphlet, we have a conversation guide where, again, it helps families ask the right questions of their healthcare provider. And then last slide is, how do I get involved? So we're just here to talk about what we've done and ask you. I want to know from you, what are you doing in the space of long-term care? What can you share with us about the practices that you've developed that you think are working for you? What you would like to do that maybe you haven't been able to do yet? And if there's ways that you think we might be able to help you in the journey that you want to go on. So that's all I had to say. Lori, what would you like to say?
So I'm going to tell you some of the questions that I asked Mary Lou when we got talking about her project. And when we talked about long-term care in First Nations communities, we weren't even sure how many long-term care homes there were, like across Canada. So 40 is an average. I suspect there's more. So the suggestion would be to do an environmental scan for one thing. And Mary Lou mentioned an interesting point that there's a home in New Brunswick that did not receive provincial funding to open a long-term care home. And I was really curious about that and wondered why. And she said they didn't want to be bothered with all these inspections and criteria. And so when I thought more about that and reflected on that, I said, wow, that's really interesting, because I'm actually in the process, you might have heard, we're developing our hospice. So we wanted it to be community-based, community funded, community driven, and it's been very difficult. So we've had to apply to the ministry, much the same as they do for a long-term care home. And so, and that's a very long process. And so the other part of that is the framework and the requirements of the Ministry of Health to do that. And so that is a deterrent in itself, because not everyone has the capability or the resources to even be able to get to that point to apply for something. And so then I says to Mary Lou, well, when I think about long-term care home, I think our folks were always, and for me, was told we have to take care of our seniors. We don't go and put them in those homes. And I thought, that has changed now. And the reality is that we have to work, we're providing, it's just surviving, living, that you have to have 2 income homes and that sort of thing and you know, we still have 3 and 4 generation families in the community living in a home. And so the idea was that the younger folks would take care of the old folks. And that's not happening now. There's a lot of things that are happening that aren't good. And so with that, I thought about the idea of the trauma is the other thing. The you know, the schools in the past, the residential schools, and now those individuals who were in those schools are now coming to long-term care, which is another facility, and it's re-triggering all that trauma again. And so those are the things that I began to think about when I talked to Mary Lou about this project. But at the same time, I went through a situation myself with my father, and I have a stepmother who was in charge. And so it came time for him to be somewhere. He was in hospital, then he went to long-term care, back to hospital, and then when we knew it was end of life, he actually was allowed to come back to the long-term care, which is in our community. And I'll be honest, I was so grateful for the care that he received there. And that's where he needed to be, because otherwise I would have had to take him home with me, because my mother-in-law wasn't going to do that. And so what we did, I was actually at a conference with Mary Lou in Ottawa, I think. I got a call from my daughter, and she says, "Mom, you need to come home. It's time." And so I thought, do I leave this palliative conference to go home and do palliative care? In the end, I did. I did do that. So the long-term care home allowed me to, and my sister and my daughter, we took turns. We went to the home and stayed at night. And so, and then I'd get up and go to work that day. And I thought, oh my gosh, how are we going to keep doing this, you know? But it didn't go on too long. But that's where he ended up passing. And I thought, yes, we needed this. And it was good. When I reflect back, the people that worked there were so receptive to us being there. We slept on the floor, whatever, you know, they fed us, whatever we needed to have done. And I thought, wow, I'm going to make sure that we have that accommodation in our hospice going forward. So that's my story.
Yeah, and the message that has come through again and again, which I understand completely, is the importance of the care being close to home.
Yeah.
And that might mean that your community is large.
Yes.
How many, 12,000?
15.
15, see?
Yeah.
So how many beds do you have?
50.
50. So having the scale for a 50-bed long-term care home isn't going to be practical or, you know, affordable in smaller communities. But we also worked in Notkinguaning, where they had an elders assisted living facility where they are looking after their long-term care clients with home care staff. And it's like 8 beds. I think they've got 8 beds. I saw Maxine was here. She's here. They're always full.
Yes.
And it prevents the need to move people out of the community to Kenora, which isn't that far, but it's still an hour and 15, and there become transportation barriers for in-community presence in the lives of the residents. So I fully respect the fact that I hope there will be many models for long-term care that will be created by communities, in communities. But in some ways, people are people, and what they need is, you know, getting back to what we've learned from SPA. I think the components of what goes into a good palliative approach will be similar, but how it will be done and who will do it has to be customized and determined, by the people that are doing it.
So to me, that means the culture, and it's being respectful of that culture. The first thing is, like, I think Gay was telling me about her situation, and maybe she'll share, but allowing the families to be present. And you're talking huge families, and kids and grandkids to be in that space and be present. And right now we can't do that in hospitals. They'll say, okay, it's visiting hours are over, everybody leave, and yet we stay with that loved one until they're gone. And so that's one area. And then the cultural piece, and we have a supportive housing too, where many of the considerations would include, we don't put someone else in that bed for 10 days. That's not always a reality of your situation, but if you can respect that piece of it, then we do. And same within the home. If someone passes in their home, like we leave that equipment there as long as the family wants it there, or otherwise they tell us. Like we take their direction when it comes to things like that. So I think it's the same in long-term care as far as, are you able to respect the cultural diversity? And no matter what the culture is, like when I did work in the hospital, I learned of all the different cultures and like when someone passes, and do you hurry up and send them to the morgue kind of thing? But no, I believe it was an Oriental family. They actually brought their loved one to the sunroom, and there was ceremony there. And I thought, wow, that's beautiful. So it's just respecting that cultural piece to say, let the family guide you on that. And they'll tell you. They will.
So maybe now I'll just, so I want to ask these techie people back there, is there anybody on Zoom? Okay.
We have no comments at this time.
Can we see them? As opposed to myself?
There's one. There's a girl.
Okay, that's great. Welcome to the people on Zoom, and I hope you feel free to join the conversation as we go along. I hope you feel free to share. I hope you feel free to ask questions, and thank you very much for being here with us today. So I want to turn it over. My questions were, what are you doing now to support residents who need long-term care? What's working really well for you in the way of approaches or supports? And is there some way that you think we could be helpful in the work that you want to do going forward? So please, anybody can share their experience. Verna, thank you. We need a mic for the people on Zoom.
Oh, okay. Is it on?
I don't hear it.
Hello?
Yeah.
Okay.
There we go.
I just wanted to make a comment about, in my early career, nursing career, I worked in a long-term care facility, and it's hard physical work, really hard physical work. As the RN, mostly you gave out medications, because all of the clients have a lot of medications. It was really difficult to provide that whole person care. And I think comparing it to the work that's done now in the palliative approach to care in the community and so on, that whole Indigenous wellness framework kind of needs to be brought into, where, the physical part of it is there, and it's only going to get worse as that client deteriorates. But trying in some way, like Lori suggested, the traditional elders coming into the home, sitting with the families, and like we all know, it's hard, like with dementia. The sad caregiver basically loses their loved one twice, really, when they don't know them anymore and when they eventually pass. I think that's huge. Just from having worked in that environment, you don't have time to do anything else. And yeah, we need more resources. I know at home, we have a few challenges in our long-term care facility, and it's based on the pandemic and not having enough staff. And I know we all saw it on the news during that time, that sad things were happening because there wasn't a lot of staff. And back in my early career, I mean, it didn't pay well either, you know, like sadly, that's what you looked at as a new RNA, where you're gonna not have to work as hard to make the money. But that's what, when we talk about improving the palliative approach to care in the long-term care facility, trying in some way to bring in that spiritual, that emotional, you know, along with the physical, and basically the traditional elders coming in the home. And I think at Iroquois Lodge, our long-term care facility, they do try. They provide, when someone dies, they'll let the family lay them out at the home. And that's been helpful to a lot of families. So yeah, that was just what I wanted to say at this point.
Thank you for that.
I want to say thank you so much, Mary Lou and Lori. My name is Natalie DeFebo, member of the SE Health First Nation Inuit and Métis team. And I really resonate with Verna and her comments around, you know, the experience in long-term care. I'm a registered nurse, and I graduated back in 2012, and I went straight into a charge nurse in long-term care role. And that was an eye-opening experience for me, but having the difficult conversations with loved ones when their family members have had a change in status. And at the time, being completely honest and green, like, how do I do this? Where do I start? Right? So I think there's so much value in the resources that you have worked on and prepared and are sharing. And now working in a PSW instructor role with the First Nation Inuit and Métis team, my goal is to continue to share that. So now learning so much about the knowledge that's being shared here over the past few days, that's something that I can help to create a ripple effect with, right? And share that as we embark on new journeys for our students who will complete a long-term care placement. And our goal on the FNIM team is to try to do that as close to home as possible.
Yeah.
So if that can be in a long-term care home within their community, that's what we aim to do, and to really integrate those Indigenous ways of knowing with the goal of reciprocity. So I just wanted to share that, and really resonated with what you've shared and what Verna shared. So thank you.
Thank you, and thank you for mentioning the personal support worker, or in some jurisdictions they would be called healthcare aides, the frontline workers. I mean, they are 80% of the staff in long-term care, and honestly, they are without a doubt the most important. Sorry, nurses. But, you know, in the work that I did in long-term care with Sharon and other, the very, very important personal relationship between the resident and the family, the person who knows their spiritual and cultural beliefs is the PSW. They are really, really a key to the success of the implementation of the palliative approach. And it is so critically important for them to take a leadership role in the quality improvement process or the development, and be a very valued part of the team, you know, because I think, you know, when we listen more to the PSWs, we do the work much, much better.
Yeah.
And I did learn very early on at Six Nations, when I was back in whatever that was, 2012, and I was saying something about end of life, and one of your elders stood up and said, You just need to know it's not the end of life.
That's right.
So smarten up, Mary Lou. It's just a transition.
That's right.
So I learned very early that it's a spiritual journey with a medical component,
Yes.
as opposed to Western medicine, where it seems to be a medical journey. We'll tag on the psychosocial, but the core is different.
And even the grief, like I know we touched on it off and on throughout the last 2 days. The PSWs, when you mention them, they're seeing those clients more than their own family. They've become the family of the client. And when that client passes and they've taken care of them for years, they're going to grieve. And so you need that support for the staff as well. And oftentimes what we found is we need to debrief, like right away. If you're feeling some sort of way, you need to at least, like as a nurse or like the charge nurse or whoever, to be observant of that. And if they're just not bouncing back, then you need to check in with them and make sure they're okay, and they need that. They need to be recognized, supported, and get the help they need to keep doing what they do.
And we have a really couple of good resources on supporting staff after the death of a resident. One was developed very early on in the work Sharon and I did, where it's kind of a sharing circle, where after the death of a resident, the staff kind of do a huddle.
Yes.
And one of our team members who had a lot of experience in post-traumatic stress debriefing, just created, it takes 15 minutes.
Yeah.
But it's the staff coming together in a huddle, acknowledging their feelings, supporting each other on what they need to do to look after themselves. And there's another set of resources on the SPA website about I can't remember the name of it, but it's Dr. Joe Hockley doing a video talking about meeting with staff and helping them. So, I acknowledge, and things also for the residents, because here the residents are sitting at a table.
Yeah.
And all of a sudden that person disappears and they need support with their own feelings. If you don't talk about it, it's like that person didn't matter. But it's also scary for them because, they're on the journey too.
Yeah.
So it has to be handled, directly and sensitively, and ceremony would be a very important way of dealing with that.
Yeah.
Yeah. Anybody else? Yeah, please go ahead.
Thanks. I'm Phil, psychologist from Saskatchewan. One of the things that we got involved in doing in Saskatchewan, and to give additional hats off to Paulette Hunter, who is part of the SPA-LTC and a colleague psychologist in Saskatoon. We formed the Saskatchewan Long-Term Care Network during COVID, and so there were lots of, which continues on in Zoom meetings and calls. And at one point we were talking about language and the languaging within long-term care culture. And it's interesting, Lori, when you talk about visiting hours, because one of my interests in both research and practical wise is discourse and discourse analysis. And so we wrangling a bit with the government and the ministry responsible to encourage this languaging, for example, of visitor and visiting, that the family are not visitors. They're the family, or the friends, or whatever the circle of care is, the circle of relationships, and to respect that, and then to actually think about the principles of palliative care, and one of those being that within the philosophy of palliative care is that the unit of care is not only the person who is moving towards the end of this journey, this part of their journey, but whoever their circle of care is, whether the family or otherwise. So as a facility, as a program, you should be caring for that unit of care, not only the individual. But then at the same time, there's this sort of tension and balance that there not too much pressure being put on the circle of care to be the sort of sole care providers, and then that means that the staff at the institution or the facility are kind of off the hook in a way, or some of them may think that the family's taking care of the person, so we'll sort of back off. So that juggling that tension, and but the language, starting with the language that you're not a visitor, you're part of the care team and part of the focus of care as well.
Thank you for that comment, and I really appreciate and agree with it. And thank you for mentioning Paulette Hunter. I couldn't begin to tell you the names of all of the team members, but we have team members in practically every province in Canada. We don't have team members all across the north, although hopefully that could change. So, we're trying to recognize that a lot of this facilitation is going to be contextual. And when you're dealing with long-term care, you're usually dealing with provincial jurisdiction. So as Lori pointed out, there's, lots of bureaucracy and red tape. So we'll be involving all of the team members that can help us. So I wonder if are there any comments or questions on Zoom?
There's a comment from Rochelle. She says, family and extended family have roles and responsibilities in primary care, family support, and also members wish reassurance.
So that was a comment about the importance of the family, and I 100% agree, and thank you for that comment, Michelle. Would anybody online like to share with us anything, if you have long-term care provision in your community, you can share with us how that's working, or what seems to be working well, things that feel important.
I'll say something. So to go forward now, for me, I'm going to go back to my community and talk to the long-term care home and let them know that there's supports out there, that they need to talk to Mary Lou for one thing. But I think that what we were talking about too is they're so busy. They're on a time regime, so busy that there's not a lot of time to sit and say, gee, we should develop our palliative team in the long-term care home. And actually, I did pose those questions back to our long-term care home, and they actually do have a team, which I was surprised. And then the other question was, do they allow like outside agencies, say the outreach team, to go in? Do they allow other nurses to go in with help with symptom control and things like that? And the answer was yes, that they do. So there's a partnership, there's a connection already there. And so I think if we reached out and said, what else can we do to help with this? Or come and join our leadership team that we have, which we've done that too.
And what can we learn from Iroquois Lodge and the work that they've done? Because your long-term care home, I think you told me, has been there 30 years. Is that right?
1983. Yeah.
So, I mean, very experienced individuals who have created a program that meets the needs of your community, and sounds like they've done a good job of it.
They're actually in the process of building a new home. So we'll see what that looks like. And more beds.
Well, your community's aging, just like the rest of us.
Yeah.
Anybody else here like to make a comment or share anything about their vision for long-term care? What they would hope to see in their community? How we might begin to work together on that? Yeah, microphone for Doris. Mike over here. Over here, Ken. Run, Ken.
So can everybody hear me? Or is it
Not too well.
a little closer?
There we
Okay.
go.
All right, so my name is Doris Bear, and I'm from Peguis, Manitoba. So we do have a long-term care home. It's only, it's small, it's 20-bed facility, and it's about 35 years old. So it's, I think we were on the replacement list for a new home, and the selection and the everything else was developed for them. However, with the palliative care in the home, and it is that families do come into the home and are with their loved ones, and when it's close to their end of life, that they take turns sleeping in the facility with them. And we acknowledge that with that, it is our practice that they have a support system in place. We do have the mental health who comes into the facility either once a week or whenever it is needed. And it's important that they have access to the services as well. For the other ones out in the community, we have the palliative care from home and community care services within the health center. And the nurses go out and do the visitation. We also have 2 rooms set up at the Percy Emore Hospital, which is located on reserve, and they have 2 large community palliative care rooms. So I think this was developed in partnership with the First Nations of Kinonjis, Fisher River, and Peguis to have this created and put together. I think it's important too that when they have their traditional knowledge and teaching brought into the palliative care, and we don't impose anything upon families. We respect how they want to, live and how they want to see their families either remain at home or, there's always supports there. And we've grown a lot. I think with the respect, the love, and the compassion that comes from all of the healthcare team, and I think with the senior center themselves. I just want to share a little story here that 2 years ago I was seconded to the senior center for a 6-month term, and it was finding out and creating new ideas on how it should be managed. And there was a lot of work to that area. Like there's mostly updating all their guidelines, and there was so much to do. And along with the staff, creating a good working relationship among staff. And I've seen backstabbing there, negativity, and I've brought all of the staff into being a more working relationship in a positive environment. and I've seen how the residents all were happy. Like, it's their home, and it's making the senior center more comfortable and living environment and a good working relationship. It was sad that I had to leave because they wanted me to stay on, and I said, I have to be back in health. Health needs me as well. And, I was pulled in two different directions, and I still have a lot to give to the community, and I've learned a lot, and I just have a lot of compassion for the work that I do and connect with leadership. Leadership is important because it brings out this support. You will know that you'll have all the supports in place. Thanks.
Thank you. Thank you so much. I think I'm going to, Ken's doing this thing with his watch. So I think we're going to have to wrap up. Ken is nodding. So thank you very much to those of you on Zoom for joining us, and thank you to all of you in the room for sharing. Take whatever resources that you want from the table. Come to see me out in the lobby tomorrow. I've got more resources, and I really encourage you either to join us for our community of practice, or share, as Lori said, share the word with others that you know that might find it helpful. I don't have much of a plan other than we'll make the path by going. We'll get the people together that have an interest and passion in improving long-term care for Indigenous people around palliative care and end-of-life issues. And we've got a couple of years of the SPA project where we're able to support, and then SE Health will take over, our collaborating partner, and infuse all this into their educational platforms. So that's the big picture. So Miigwech, thank you very much for coming.